excited. Without further ado, guys, we can totally dive in. I already gave them a little bit of an intro as to kind of like how we know each other. So I don't know if I mentioned this, but we used to train together at the same gym. And that's kind of how I got to know Alwyn. He's a chiropractor, does acupuncture. And like I said, he really fixed me right up. The couple times that I have been injured, I was like back training. And I also did a couple lifting courses with Alwyn. So really learned a lot about the fundamentals of a squat, deadlift. And I know you, honestly, guys, Alwyn's super humble, but this guy can lift freaking heavy. Like, first of all, Alwyn, what's your max squat? Just out of curiosity.
405.
This guy's
it goes up and down, but that's four plate. That's kind of my claim to fame. So,
and he's squatting.
I'm trying to go heavier, but it's a while.
That's freaking crazy. Like, when I see you squatting and he goes A to G, it's crazy. So this guy's the real deal, and super pumped to have you here. So tell us more about, like, aside from your amazing freaking 405 squat, tell us about you and what you do.
So as you mentioned, I appreciate, first of all, thank you for having me. I'm very excited to be on this chat. So I am a chiropractor. I'm going to age myself. I've been practicing for about 20 years. So I do traditional chiropractic, acupuncture, and active release. And that's kind of my main thing now. Prior to that, I was a personal trainer. The industry was very different back then when I got into it. So I did that while I was putting myself through school. So I've always had one foot kind of in the gym and one foot in the clinic. And there was a couple of years where I got away from training just because I was starting my business and I was kind of getting into the clinical world. But I found that, I mean, hey, just without getting too deep or philosophical, I love the gym. The gym's kind of my home. I grew up. I was a decent athlete. I wasn't great, but I like training more than I like playing sports. And I just got to a point when I was about 15 or 16, and I thought, you know what? I'm not going to be a pro athlete, so maybe I'll just kind of go that route. And I was always really small too, so kind of the gym was something that I was good at. I liked it, and it opened up a lot of doors for me, not only physically but more like professionally. Tiana and I just my world. I've met a lot of good people, both personally and professionally, because of the time in the gym and personal training and whatnot. So that's kind of my background. And yeah, so right now I practice, I'm sure Tiana told that, in London and in Toronto. It's kind of a weird setup, but it works. So I'm 3.5 days in London, a day and a half in Toronto. Again, just focusing on the clinical stuff. And I do get a lot of questions about training, but I find, and this isn't to sound like really just kind of cliched. I know a lot of good trainers, so I tend to refer out quite a bit. So when people ask me, it's not that I don't give that advice. I refer out to Tiana or Brian, for example, because that's what you guys do every day. So that's kind of my professional portfolio.
I love it. That's awesome. So like you said, you were, first of all, an athlete, loved training yourself, and then now you're on the clinical side of things. So I'm curious, like, based on the people you work with in your practice now, what are kind of the common imbalances that you're noticing? Like, what are people coming to you for?
So again, just to answer that question, I see a lot of people like yourselves, probably a bit older. So I see a lot of low backs, ton of low backs, obviously, shoulders and knees. Those are the kind of the main ones. That's probably 75% of my practice. And then because I see people like you guys.
Oh, hold on, you froze there. Is that just for me, or is he's frozen, right?
Yeah, he's frozen.
Yeah, he's frozen.
Poor Alwyn, he is having some tech time tonight.
I know. I don't know what's going on. Maybe it's connection.
Poor guy.
Oh, he popped off. There's something going on with his internet probably. I'm just staying on standby in case he needs something. I have the code for him. Yeah, it happens. Sometimes like, I don't know if you guys remember before COVID, like nobody really used Zoom. They did, but like not as much by far. Especially not if you didn't do it for work, like it wasn't a thing. Now you can pretty much see anyone through Zoom. It's like used to work for a telco and it's hilarious when we get internet difficulties in meetings. Man, it's pretty wild. Like I don't know if you guys remember, those of you who have small kids, but during the lockdowns when we had to log in and the kids would be alone with the computers and they didn't know how to use them, and it was just a crazy time. What a life. Yeah, PTSD for me too. My son was in kindergarten and after a while I'm like, I'm not putting him on the screen all day. Like half adults don't freaking know how to use this thing, let alone him. I'm not doing it. Had a grade 10 kid in school. Most of our teachers were challenged by Zoom. Yes. Yeah, so guys, oh, here we go. Alvin's back. You there, Alwyn?
Am I on mute?
No, you froze and then you left and then came back.
Okay, can you guys hear me?
Yeah, we can hear
Yeah,
you
it's
now.
on. I got booted out of my app. But yeah, as I was saying, I see a lot of low backs, a lot of shoulders, a lot of knees. But I also, and this is the fun part of my practice is, you mentioned squatting and various exercises. I have people that come in that want to specifically work on those areas, which is kind of neat. It gets me out of that typical kind of Chiro 101, and it allows me to kind of explore and keep learning some of these lifts and some of these other movements. So
Oh, that's awesome. So in your session, you're saying when you're doing your manual therapy, they'll be doing like their squat and their deadlift as well?
yeah, exactly. So my practice, as you know, I treat it a little bit differently. I spend a lot of time. I book all my sessions for about 45 minutes. So, doing active release, doing acupuncture, and some of the tests that we'll do, and I think that this is kind of maybe the topic of this conversation. We try to identify a dysfunction, but the problem is with people that are really fit, you can't always do that on the table. So you need people to move. So if you have back pain, or let's say I do a muscle test, and I test your glutes. Someone like you, for example, is going to be pretty strong. So even if there's a dysfunction, I'm not going to notice it with a typical test. So maybe we have to challenge the body a little bit more and get you into like a Bulgarian squat position, or get you into a hip thrust position in order to really get that dysfunction out and tease that out. And sometimes the challenging thing about being in a clinic is, so my clinic in London, it's a typical clinic, but at least in Toronto, we have a lot of weights. So sometimes we'll put someone under load to see what the issue is, especially if someone's quite strong. So.
That's a really good point because sometimes if you're an athlete, it's often not when you're just at rest that you kind of feel these injuries coming on. It's like, oh, I'm lifting. And then it's like if you're in clinic, it's kind of like I was saying earlier to the girls, like I made a post today, like people I find tend to separate the two things. I don't know if you find the same. It's like they think, oh, when I'm lifting and I'm in tip-top shape, like I'm going ham. And then when I'm injured, like I'm doing these like very light physio exercises. Like I think there's an in-between, right? Like there's kind of like a medium. So that's kind of my next question. Like a lot of our girls will have what you're saying, the bad knees, bad back, that always comes up. So let's say you get injured here. Like what would you advise? Like how should we modify training in this case?
Yeah, good question. And I think this is going to get another cliche answer is, I think it's really important. I think it's where the collaboration comes in, is knowing exactly what the issue is. So for example, let's say you look at everything through a chiropractic lens. We'll say, there's something wrong with the joint. Well, if you look at it through a physio lens, we might say there's something wrong with the hip. But I think it's important to kind of get rid of those dogmatic biases and find out exactly what's going on. So if we were to keep it really kind of basic, and we were to say, okay, let's say someone's injured, and any body part, let's say it's a joint injury. Well, that joint injury can be trained around because we have compensatory muscles, we have different movement patterns we can focus on. Whereas if the muscle is injured, we may want to avoid that movement because we're actually stressing the muscle. So
Mhm.
sometimes we need the muscle to get stronger to protect the joint if the muscle's fine, but the joint is injured. But if the muscle is injured, maybe we need to give that muscle or that muscle time to rest and time to heal. So from a modification of training, and I think, again, I'll speak for myself, sometimes we overcomplicate it. We're not as smart as we think we are. And so let's say you injure your shoulder, maybe you can keep training legs heavy and training core heavy. Like we often think that we should do rehab for the whole body. Well, no, let's just kind of set that body part aside and keep training hard for everything else. Or keep training the way you were training before the injury.
Yeah, that's a really good point. But and then okay, so let's say in a scenario, like if you guys have any scenarios, drop them in the chat. Like kind of like, we're not going to give you medical advice, obviously, but like if you let's say, hey, gone to the doctor, oh, you have this going on. Like what are you guys dealing with, those of you who have injuries? Like I'll give you an example, Alwyn. Let's say I'm deadlifting, I'm doing an RDL, and I feel a twinge in my low back, and then it starts getting worse as the days go on. Like, would you like my first thought is like, okay, we're, not going to do any hinged movements where the spine's not supported, but I can still lift, right? Like I can still lift and do upper body. I can still do chest supported. Or what do you think about that?
I would even add one more in there. You could even do like leg extensions, hamstring curls, like anything on a machine. And I think sometimes maybe getting away from the big compound lifts that we all love, hopping on a machine for a bit and still training while you're protecting your back. Here's a kind of a little dirty secret that one of my mentors taught me, that he's like, if anyone has a lower back issue, so 99 times out of 100, if someone has a lower back issue based on something like that, go to the hip flexors. Normally the hip flexors are going to act up to protect the lower back.
Mm-hmm.
If someone has a shoulder injury and you're not quite sure what it is, but it's nothing too pathological, it's nothing too sinister, we go right to the subscapularis. So from a treatment perspective, yeah, you may want to lay off. Oh, sorry, the last part is probably the most important, and I kind of add this to his mix, is most back injuries, and again, to uncomplicate things, just keep the spine in neutral. If we can keep the spine in neutral while you're training, so there's not too much extension, which can exacerbate certain things, and there's not too much flexion that can exacerbate a disc, you should be good. The challenge for most people is that spine moves back and forth, and that's why I'm a big proponent, and a lot of my colleagues might disagree with me, is put a belt on. Put a belt on, wrap it up nice and tight, keep your spine in neutral, keep moving.
Yeah, I love that. That's actually brings me to like a sub question too. Like, I don't know if you guys have heard this. There's been a lot of talk of like, what is a neutral spine? Because the spine doesn't stay in like that normal, like kind of position in daily life. So like, how much movement are we looking for in lifts? Like you're saying
Okay,
none.
I just saw Katrina's question about what's ideal posture. I
Yeah.
love that question because ideal posture is not static. I'm going to steal this from Stu McGill, and I love this analogy. And he talks about a neutral zone. In that neutral zone, so if we look at all of our spines, they're all going to be a little bit different.
Mm-hmm.
That neutral zone, if you can picture the end range of motion of any joint, let's look at the lumbar spine being where the ligaments get stressed out. We want to limit that range of motion so we never put any stress on the ligaments, and that's a neutral zone. So if we're flexing forward or we're extending backwards, as long as the muscles, even muscles that are injured, can prevent us from putting stress on either side or either end range of the ligaments, then we're good. I'm not sure if I explained that well. So generally speaking, your range of motion of the ligament, if you're putting stress on the ligaments, it means muscles have failed. So muscles are dynamic and they can limit that range. So that's one of the reasons why we should keep training, because we want to make sure those muscles stay active enough in order to take pressure off the ligaments.
Yeah, that is such an excellent point. And earlier before you came on, Marla was saying her husband had back surgery recently, and like one of the parts of his, you'd think some people would think, oh, you had a surgery, or like obviously it's going to be dependent on the person's case, but like the recommendation is always going to be to move more, right? Like as much as you can, as much as you're able to help with healing. So like you said, like if you don't use it, you lose it, right? Like you're not going to be able to heal unless you're getting some movement in.
Exactly. I mean, you probably know Susie from Good Life. She's an instructor.
Oh, I know Susie. Yeah, small world.
So I'm actually thinking this week. I don't think she'd be mad that I'm bringing her name up, but she's someone I talk to quite a bit. As like she's brilliant. She has this philosophy, and she came upon an accident accidentally, but I loved it. And she said she would train people to move within the tiniest range of motion while they can still feel a muscle. And I
Mhm.
said, like, what was your rationale for that? She's like, well, how can you create big movement if you can't control small movements? I was like,
Mhm.
that makes a lot of sense. So if someone's injured, like your colleague's husband or your client's husband, well, maybe we train within a smaller range of motion until you can tolerate a greater range of motion
Mhm.
without giving up. And I think that's probably the best approach with an injury.
I love that you said that because let me tell you, a lot of my clients, the way that I coach is like, I don't like to ever say like, okay, this movement doesn't feel good. We're just going to nix it right out, right? Like for example, lunges. A lot of people say, oh, well, my knees are not 100%. And my first thought is like, okay, great. But like, we also need to strengthen your hamstrings and your quads. And we want to safely like work the knees through like a range of motion they can control. So like, I would rather do like a partial range or like a modified lunge or like elevate the foot or like use a band as a distraction and then or like use lighter weight or just body weight, and then if that feels good then we progress. But I think where a lot of people I'd love to know what you think too, Alwyn, but where a lot of people go wrong is they're like, well, a lunge hurt me once and a lunge, I'm not doing a lunge ever again, like I'm not lunging. And can you guys relate to that? Like have you guys ever been there?
Oh
Like
yeah,
yeah,
yeah.
no, go ahead.
I think I think there's a couple of different tangents we can take with this. And again, I'm not a psychologist or a psychiatrist, but I think it gets into our brains as well. You
Mhm.
hear yourself lunge, and all of a sudden that brain map that identifies the lunge with pain grows. So maybe we need to retrain the brain to say, okay, well, we can do a lunge safely and
Mhm.
rewire that brain like, from a neuroplastic perspective, saying, okay, we can do this safely, so why can't we do it safely? And I think that pain pattern from a chronic pain pattern gets stuck in our heads. And the more we stop moving, the less we move, the more that gets imprinted.
Marilyn, actually, would you mind sharing? Because you can relate to this, I'm sure, with your
Of
situation.
course. Alan, everything you're saying is totally resonating with me. I had a back injury in 2016 and it was very painful. And for a little while, I couldn't actually do much because it was just like debilitating pain. But as I started to get back into it, that was actually, in fairness, that's kind of what I was told back then was like, well, don't do resistance training. You should only do cardio. But I was so into resistance training. So part of it was being stubborn. But I wanted to get back into it. And I knew that I needed to do that to get better. Anyway, fast forward, I haven't done like squats or deadlifts for what I thought was like my body not letting me do it. I have a physiotherapist who's really amazing and actually is studying exactly that, how our mind holds us up sometimes more than our body when we're dealing with chronic illness. So we're doing a ton of work, like it is therapy. So I'm actually working with my therapist and my physiotherapist on moving through all those blockages because so much that was holding me up was my mind. So
Mhm.
anyway, I squatted 75 pounds today, which is huge for me. Like, I mean,
Awesome.
yeah. So
Well,
I
that,
totally,
that's amazing.
yeah. And I was told like, you'll never squat again. You'll never deadlift again. Like I was fully told by my doctor, never again. And anyway, it's amazing. And I've actually grown so much and strengthened like my body and my mind through this whole process.
That's amazing. And, that's something we get excited about because
Yeah.
you were told you could never do this again. So, yeah, that's awesome.
Yeah.
Hey, thank you.
Yeah. Thank you.
So that was actually kind of like my next question, Alwyn. Let's say, and let me know if you guys can relate to this, who's been in this situation. You might have a more old school, I know you and I were talking about this, Alwyn, but you have an old school person, let's say, who you go to your healthcare provider. Oh, I twinged my back a little bit. Well, we want you to lay off the weights completely. So why does this happen? Like, what are your thoughts on that?
Okay, so you and I were texting a little bit a couple days ago. So bear with me. This is going to come across as pseudo philosophical, for lack of a better way to describe it. I think I have a couple of reasons where I think the old school people are resistant to this. And I don't think it's sinister. Like, I think, we'll look at, and like I said, I have my feet on both sides. I don't think healthcare professionals are trying to make people worse. I don't think they're avoiding giving people good advice. I think it's a very inherent subconscious thing. And I think this is going to sound kind of silly, but I think, like the message that I sent you, that we live and we operate in a world of dysfunction. That's us as healthcare professionals. Someone's sick, someone's injured, someone's ill, something's not going right. That's where we provide value. What I don't think is dysfunctional is weakness. But I think a lot of healthcare practitioners think that weakness that's leading to pain, discomfort, or illness or whatever is something pathological. And I think that's where the challenge is, because if a healthcare professional, put us all in the same boat, sees something as dysfunctional, then that means you need treatment. You need to go see it. You need to see me. You need to see your doctor. You need to see your physio. And I think a lot of healthcare practitioners subconsciously keep people in that state of dysfunction. I think just from a clinical perspective, but also from a business perspective, like that's how we make our money. And again, I don't mean that to be sinister or malicious. I think just subconsciously, that's kind of where our head is at. I think the other thing, and I think this our minds and our hearts are in the right place, is if we say, okay, you're injured, you have a bad knee or a bad hip, and you go and train, I think there's that fear that, we might be putting something out there to get re-injured again, and we don't want to do that. I think the third thing. I think the big thing is, and I'll tell a little story. So I got invited to the chiropractic college a couple of years ago to do a lecture. And it was when I lived in the States for a while, and they wanted me to talk about working with pro athletes. And I don't see many of them anymore. I did that for a short period. It was fun. It's not really my demographic anymore. I said, I come in, I want to talk about bridging the world of strength and conditioning in clinical work, exactly what we're talking about. So we did, it was very tongue in cheek. We did, myself at a college, we did 10 points. These are the 10 points you need to consider if you're going to work with trainers. So we did the first 9, and we said, okay, forget those 9. Those 9 aren't important. And we went and we grabbed a bunch of empty bars, and we said, squat. I said, if you guys go to a gym and you can't squat, you can't lift, trainers, you're not going to have credibility with trainers because they know you don't live it. And I think the point is, a lot of healthcare practitioners don't live it. So they don't understand that what she said earlier, that, well, maybe just moving is exactly what I needed. And I think until you internalize that, you're hesitant to give patients advice on that. And I don't think it comes from a bad place. I just think it comes from a very, you don't know what you don't know. So I think that's where the mentality comes in. And I think the other thing too is, we look at healthcare as a hierarchy. So you have, the orthopedic surgeons and the neurologists at the top, followed by the GPs and so on and so forth. I think we need to take that vertical hierarchy and flatten it out and say, okay, well, people are going to come in at different, like not everyone has to come to the top. We flatten it out. Maybe your challenge is, maybe you just need to get stronger. Maybe that's where you should enter the injury rehab phase. Or maybe your diet sucks. You're training well, you're getting all the treatment, but you eat like crap and you drink too much, so you're not going to heal. The guy that I learned from the most was my acupuncture instructor. He was brilliant. He's the smartest guy I've ever met. Zero ego. And he'd be like, it's really important to have a good assessment and diagnosis, but he's like, in order to have one, you have to realize you may not be the person that person needs. I was like, oh, interesting. So in that course, we dealt a lot with psychology. He's like, sometimes people need a good psychologist before they need a good acupuncturist. So it kind of reframed my thinking. And, he's like, maybe it's nutrition, maybe it's training. But he's like, we have to flatten that out and be objective with it and understand that our skill set may not be what that patient or that client or that individual needs. I think that's the biggest challenge.
Yeah, I love that point too. And I think that, like you said, in the beginning, if someone is not lifting themselves, right, they don't have that firsthand experience, or it's one thing to kind of This is my interpretation. Like, it's one thing to read about it, right? And say like, oh, lifting is beneficial, but then they might like look at the risk on paper and be like, well, I don't want you to re-injure yourself, but having someone who like is open, and does have that firsthand, and like you said, that mentality, like, hey, maybe this isn't what you need right now, but like, someone else might be able to help you. That's when you get that most well-rounded approach. And really it comes down to like having at the end of the day, like your provider, your trainer, your physio, whoever you're working with, they got to care about you getting better. So that's the only way that, they're going to advocate for you. And Katrina made a really good point here. I'm just going to read what she said here in the chat. And then I think a couple of people have questions. She's a doctor and she said, I will say physiology and kinesiology is not always carried through in medical doctors training unless we choose to. So knowledge base is not always there, but hopefully your GP will point you to the right direction. Yeah.
Absolutely. And I will say, sometimes when we have these talks, it seems very divisive. It's funny, and I think, you kind of attract your tribe. Some of my most fit patients are MDs, which is amazing because it's kind of a nice counterpoint to what we tend to see in the big picture.
Yeah, I love that. And Christy had a question as well. I want to make sure because I know she's had an injury that's been bothering her. Christy, are you on here? Do you want to unmute? I can.
Yeah, sorry, can you hear me?
Yeah, we can hear you.
Okay. Yeah, so I had just last month had injured I guess my back after doing an RDL. I felt a twinge and then I kind of carried on with my workout and then I ended up getting into my car, driving to work, and then as soon as I stepped out of my car, it was game over. I've never experienced pain like that. It was worse than my labor pain. I was down and out like for a month and I got better, but unfortunately now what I'm dealing with is my back is fine, but now my left side, because it was always my left side, sorry, mid calf to my foot, I'm dealing with what I've been told is nerve pain. And it's also excruciating, and it's the weirdest thing. So it's literally just my mid calf to my foot. And like my GP basically just sent me for an MRI, which I'm waiting for the results, and medication. So obviously now I'm trying to do physio to alleviate the pain. But are you knowledgeable in nerve pain and how I can treat this or go forward?
I'm going to give a textbook answer without seeing. It's hard, you can't really make a diagnosis.
Yeah, I understand. Yeah.
Yes. And not to be cavalier about this, not to be dismissive. That sounds pretty textbook from, the nature of the twinge, the RDL, the calf and the foot pain. If you're put that in Dr. Google or do a textbook, it'd be like a sciatic nerve compression anywhere along that chain. Oftentimes what happens, and it's interesting because we think, we blow out a disc. Okay, I'll use a different example, but I'll circle back to yours. As the easiest thing to heal is a broken bone because your body's going to take care of it itself. So if someone comes in with a fracture, I'm like, listen, that's kind of outside of my scope. Cast it, just do your medical 101 on it, and then be done with it. But what happens is it's the compensatory patterns. So the muscle going into spasm along the piriformis of the hamstring. All the things that are trying to protect that initial injury are normally what causes the symptoms down the road. And again, without knowing your case, there's probably a lot of things I'm missing. But you mentioned you got injured, you drove to work, game over. And the telltale sign with that is you got fine and then it got worse, which means the initial injury probably healed, but now your body's going into like a protective pattern. And that's a brain protecting yourself. So the good part about that, and again, I think you're on the right path, getting the MRI and everything, is the frustrating part is, you get all the imaging and they tell you there's nothing wrong. But the good thing to keep in mind is sometimes ruling things out is part of the process. So let's just as a very general example, you have sciatic, you have pain in your calf and your foot, nerve pain. That can be coming from a very general way to describe it, a herniated disc, or it can be coming from the piriformis. So we have, a disc damage and inflammation or a tight muscle and spasm. Same symptoms, different causes. So I've run into the opposite side where I'm treating someone and I'm thinking, it's piriformis, I'm not really giving it enough credit. They don't get better. We send them off for an X-ray or MRI, and then they find out they have a herniated or degenerative disc. So I think if you can tolerate that long process of getting all that imaging done and going through the medical route first to rule things out is actually not a bad idea.
Mhm.
Okay, thank you.
No problem.
All right, guys, I know we started a little bit later, but we'll leave room maybe for like a couple questions, Elwin, if you have time.
Yeah, of course. I have time.
Awesome. So guys, if you have a couple questions, unmute yourself or drop it in the chat. We'll have,
Actually, while I'm waiting for the questions, I have two interesting points that I tend to. You talk about, there's an injury and treatment, and then there's training, right? So you have dysfunction and function. I
Mhm.
think there's a very small space that's not really addressed. Now, what do you do in between those two stages? Like, how do let's say you're training to really, your body composition. That's kind of our thing, right? But what if we can't train that hard to stimulate those changes, but you don't need treatment? I found two really interesting things that people can kind of do on their own. Okay, so here's another story. Sorry, I can ramble on. Is we would do charity events, and we would do them for women's 10K. So the 1 year, myself, physio, two physios, and an MD. So we would just do like very gentle massage. We show them stretches, and we would kinesiotape them. So they'd come in, they came to the booth. We taped them before they ran. We did the same race the next year at Sunnybrook, and all the participants. Now, keep in mind, this is like a Sunday afternoon 10K. No one's breaking records. It's all done for fun. Kids are running around. The same people that were running this had taped themselves. We thought, interesting. In 1 year, this whole thing that no one had heard about, people just kind of adopted doing it on themselves, which I think is amazing because it's giving people autonomy. So to that point, I think what I like to do is if there's a muscle that's not functioning right in a movement, let's say a complex movement pattern, you're squatting, your glutes aren't firing. I know that sounds, a very generic way of looking at this. Maybe using kinesio tape to stabilize the joint or to activate the muscle. Now, this is where we as healthcare practitioners try to be very territorial and say, no, you shouldn't tape yourself because we should be taping you. People are taping themselves. So best thing to do, buy it off the shelf, learn how to do it properly, and use that as a way to allow yourself to keep training. The other thing I really like, and this was a really cool study, that a lot of people that had injuries, the injury healed, but some people would still re-injure the same body part.
Mhm.
And the biggest difference was people were strong enough. Both groups were just as strong. The group that didn't injure themselves, they used metronome-based tempo training, very bodybuilding. And that tempo training forces you to contract a muscle through the full range of motion. Game changer. I'm a big fan of bodybuilding training, just because I think it's easy on the joints, it's very controlled, but it's very neurologically sensitive that it actually prevents further injury. So those are just my 2 points.
Yeah, that was kind of one of my questions, actually. Like, what can people do to prevent recurring injuries once they, are back at it? So I guess, like you said, like control tempo, controlling the movement, so the kinesio tape, I don't know if any of us have been familiar, maybe some of us have used it, but would you say even adding like the belt, I know you're a fan of, some type of external like support you're saying, like a knee brace, like that kind of stuff?
Yeah, and again, that's where to everyone's as a healthcare practitioner, our discretion, but also your discretion. Like use it until you don't need to use it anymore.
Yes.
Or the alternative is use it. Let's say you're squatting really heavy. At some point, every movement's gonna have weak muscles, like no matter what we do. So maybe you throw on a knee brace so you can lift heavier, but be sure to train that knee with that brace with another exercise. I think the big thing, I think the missing link, and I think it's a missing link because as healthcare practitioners, we have people at a table in the gym. We're lifting heavy weights, doing your typical program. I think there's that neuromuscular component that when people, for example, you do the Romanian deadlift, you twin your back. Maybe let's just assume that nerve pain is coming from the piriformis that's pinching the nerve. Oftentimes, what a muscle will do after the joint is injured, it loses its ability to contract appropriately. So
Mm.
contract much. So we get tight. And what do? We stretch it out. Well, maybe we need to train that muscle to not contract 100%, to contract 50%. And I think that's where training is fun, but it just, you need to be patient with it. That maybe the lower the weight, lower the range of, or play with your ranges of motion, play with the load, and maybe switch the movements up a little bit in order to be able to target those muscles appropriately.
That's such a good point, because the one thing I'll leave you with is this. Before you came on, I was saying this, like, we've all been, you know, we're all saying, oh, I have tight hamstrings. And like, we've all been doing that sit and reach stretch, I was saying, since elementary school, right? Like in like gym class. And I'm like, well, why are we all still having tight hamstrings then, right? Like it's
Thank
not
you.
enough to do a sit and reach. Like I
Thank you.
honestly, yeah, like, you know what? I always used to have the tightest hip flexors ever. And they would like burn after like doing simple things, and tight, you know, hamstrings. And I found that like when I actually began properly, like, you know, doing heavy squats, heavy lunges, like heavy RDLs, and now I'm like, you know, like I'm strong in every range of motion, and I'm not like so stiff all the time, you know? Like if it's a difference between flexibility and actually like training and getting strong in the full range of motion.
Totally agree. There's so many cool like isometric training. Pilates I did a long time, and this is me being a bro and being closed-minded. I herniated a disc when I was 25, when I was doing bodybuilding shows.
Mm.
Pilates is what saved me, and then I got away from it because I'm like, I'm not doing Pilates. I'm like, oh, wait a second, maybe Pilates incorporated with heavy, like it's gonna. I think Pilates is gonna give you that joint stability. It may not give you the body and the strength you want, but I think it's a neat way. And I kind of had to swallow my ego and be like, okay, well, maybe getting back into something like that along with heavy lifting was what allowed me to stay flexible. Like
You know,
flexible, like
yeah, I was gonna say I'm totally in the same boat as you. I think I had a little bit of a bias toward Pilates because people will say like, oh, it'll get you the body you want, but like we all know that's gonna come from like, you know, building more muscle. But yeah, like in terms of stability, like your deep core muscles, like even like, you know, coordination, like all these things, like I think that these things can definitely be complementary. And I think that's kind of like a good, like, you know, wrap up of all this. It's like it doesn't need to be one modality. It's like all of them working together.
I'm going to send you. So I have a bunch of. So I used to teach a course on kinesio taping. I'm going to send you the link. They're all videos on YouTube. I also this is me being totally biased, and I think there's a positive and negative to this. So you know, I have to maybe not look at everything through my lens, but I think that's why I can appreciate people that lift weights. So I'll send you guys a series of hip videos, and I send these to people all the time. So I just put them on my YouTube channel with a colleague of mine. She demonstrated them, and they're for the deep hip muscles, so the lateral rotators, the glutes, all that stuff. My hamstring flexibility, if I do one set of those exercises, my hamstrings lengthen by about 5 inches. If I'm tight, it's because my hips are unstable. And so again, my bias is, well, it worked for me, so maybe it's going to work for other people. So I think from the big picture of weight training, it's good, but everyone's different though, so I got to keep that in mind.
I love that. No, Alwyn, I'd be happy for you to share. And actually, on that note, where can we find you? What are your maybe can you leave your social handles in the chat and your YouTube?
Yeah, we'll do. I'm based out of London and Toronto, but everything, you can find me on my Instagram page at Dr. Alwyn Wong. But I will send that in the chat.
Okay, awesome. Or you can send it to me and I'll share it when I share the replay.
Thank you.
All right, thank you, Alwyn. It was a pleasure having you on here. Thank you so much.
Thank you very much. I was honored, and sorry for the mishap at the start too. My bad.
No worries, no worries. Thank you so much. Have a good night.
You too.